Welcome, everyone, to the July Coffee with a Clinician. I'm Clayton Powers, and I'll be facilitating today's discussion. I'm a doctor of physical therapy specializing in the care of individuals with complex health conditions, and also I'm the director of education at Bateman Horne Center. Before we begin, we want to thank the donors whose support makes this possible. Thank you so much for your donations so that we can make this accessible. For this session, Dr. Cindy Bateman, Cynthia Peterson, and Dr. Janet Mullington will discuss Chapter 5 of the Clinical Care Guide titled Sleep Challenges. We will also answer questions that participants have written in the Q&A feature. And as a reminder, we cannot provide medical advice. And we're so excited and thankful for our panelists joining us today. Dr. Lucinda Bateman is an internationally recognized researcher, clinician, and educator in the field of ME/CFS and related conditions. She's the founder and chief medical officer of the Bateman Horne Center and has spent more than 2 decades advancing patient-centered care, research, and medical education. And then Cynthia Peterson is a physical therapist with more than 36 years of experience helping patients and professionals master the ABCs of whole human health, airway and breathing, brain and nervous system, cranial orofacial, myofunctional health, sleep and whole body postures and connections. And Cynthia is also a published researcher, author of the TMJ Healing Plan, and Cynthia also trains and teaches professionals and owns a private practice based in Salt Lake City, Utah. Dr. Janet Mullington is professor of neurology at the Beth Israel Deaconess Medical Center and Harvard Medical School. Her area of expertise and research is in sleep deficiency and its associated pathobiological consequences for systems, including inflammatory, autonomic, state-related neurophysiology, cognitive and subjective fatigue, and mood. Dr. Mullington is also part of the Recover studies looking at long COVID and ME/CFS and doing research in the realm of sleep. So we'll start with Cynthia Peterson's going to share some slides with us, and then we'll have a discussion about sleep and sleep issues. All right, go ahead, Cynthia.
Perfect. All right. I am so honored to be here. And first, I just want to say that you are seen and truly cared about. I feel so honored to be connected sometimes with the Bateman Horne. I get to visit their professional groups. They are passionate, professional, and have such a purpose. I totally donate money to them because I know that they are in the trenches doing good things for you. They want to help you. And I do have a family member with chronic fatigue and chronic pain. And I hear and I see and care about you. I'm just going to quick share a few thoughts about orofacial myofunctional therapy and breathing for better sleep. So let's get to it here. All right. So I want to share a quick study. There was a systematic review and meta-analysis. That's a big word for meaning a really big study where they looked at orofacial myofunctional therapy helping people with obstructive sleep apnea. And they showed it can improve 50% in adults, 62% in children. But what is orofacial myofunctional therapy? I had never heard about it. Even after I'd written my book, The TMJ Healing Plan, I taught classes on a neck and back and jaw school. And someone called and said, "This is the best book about myofunctional therapy." I said, "Myo, what? What is this?" So basically, it is these topics. So I teach in my book and in my classes, these are the healthy habits I'm passionate about. And sleep is right there with breathing, number one. But myofunctional therapy is being able to seal your lips with your tongue up, healthy, keeping your teeth apart, and healthy swallowing. And so I added posture and breathing. I believe breathing is the foundation for everything. and calming and balancing the nervous system. And I love to go fast, but I will slow down. So there is, let's see, keep going. So, how is breathing different at night? So, I just wanted to quick show you a little glimpse. This is someone laying down. This is their nose, their nasal airway, their mouth. This is their pharyngeal passageway that goes to the lungs. Okay, and we want that free and obstructed. And this is an example. Here in the middle, you can see that it's a partial obstruction, and here's a full obstruction, and that is called obstructive sleep apnea. You can also have central sleep apnea, where the brain has difficulty that often is related to chemistry. It like forgets to tell you to breathe. And often in women, we can have upper airway resistance. So sometimes the sleep study will look fine. We don't have obstructive or central, but you can have upper airway resistance. And we won't get into all of that, but what you need to know is basically if breathing takes effort, the body works harder all night, and you can wake up feeling exhausted instead of rested. And this can often cause little micro wakings or arousals, and you don't even know that you're waking up. The brain can turn into fight flight because all night it's working to help you breathe. And then you get into this, it can feed that fight flight sympathetic nervous system. I believe in precision care, and I think the Bateman Horn and people like Janet Mullington, Dr. Mullington, totally do as well. And they are working and researching to find the answers because we must treat the why, the underlying issues. It's not usually one thing, it's 5 or 10 things to get the wow, which are the wonderful outcomes we want. And these are just some examples. This is someone's tonsils who changed in 5 days. This took 1 year. And when they looked at this, I treat from womb to tomb. I'm trying to prevent the pains and problems I see that many of you suffer from. But this person has an amazing airway. And you can see this took 2 years of healthy head, neck, jaw, whole body function. This person thought they had a tongue issue that was affecting their breathing. And again, this changed in one session. Does that always happen? No. But when we have precision care with medical and our team of providers, we can figure it out slow and steady what it is for you. That is our goal. And I was so passionate about it. I knew we needed research. So I came up with an idea for a pictorial tool that would help identify people earlier who are at risk for sleep disordered breathing. That's breathing problems during sleep. So I presented my idea. It's a functional airway evaluation screening tool in 2017. And what this means to you, and this was then validated as a screening tool, and this is for pediatrics, but it applies to us all. If you can't breathe through your nose for 3 minutes, that's a red flag. If it's effortful for you to keep your lips closed, like when you just totally relax, do your lips pop open? That's a red flag. If you were to look in your mouth and say, ah, can you see your tonsils and are they big? If they are enlarged more than 50%, that's a red flag. If your tongue's tied, that can be a concern. If you have signs that your teeth are wearing down because you're clenching at night, that is a red flag. If you look at the roof of your mouth and it's narrow, that is also a red flag. So those are some things that you can do. And I love the guidelines that Bateman Horn's coming out with. It inspired me to come up with this little drawing that ChatGPT helped me make cute for you. It's free for you to download. And these are just some ideas. You need to make time for sleep, for deep sleep that restores. So there's tons of hygiene things, and they may talk about others, but we need a dark, cool, quiet environment. We need to erase our worries, keep things peaceful and positive. So as we go to bed, we want to feel safe and relaxed, and then focus on our breathing. Number one, we want to slow our breath. So try it with me. So see if you can take your breath, make it slower. And then feel your rib cage, feel down low. See if you put your hands around, if you can feel, is the air coming up here or down low? Try to move your air lower in the rib cage. And then see if you can, if you hold your hand around your rib cage, can you feel movement just in the front, the sides, or in the back? We want three-dimensional breathing. It should be effortless, and we want a position for success. And here's a little QR code, and you can download that for free. Um, just a quick example of why position is so important. This is my breathing test. Okay, I have positional sleep apnea. On my back, this shows that my oxygen can drop into the 70s. It should be like 95 to 98. Okay, and just by rolling on my side, for me, that improved by 10% better. It was in the 80s instead of the 70s, which still isn't good. I had to do some therapy and other work. So I just wanted to share a few of these things. Thank you to each of you for being here. Bateman Horn Center for all you do. We are all better together. There's a fun little 1-minute rap that you can listen to on YouTube that helps you remember some of those healthy habits. And here's my contact information. And it's such an honor to be here. Thanks.
Thank you, Cynthia. That was great.
Okay.
Do you, with the, and thank you for providing that resource for patients to be able to use. We can send that out in the email afterwards. Um, in your work with patients over time, have you seen that by addressing these things that sleep can improve sleep quality and things with working with myofunctional therapy or myofascial?
Absolutely. And what's so interesting is orofacial myofunctional therapy, you have to be careful. Everything hinges on breathing. So you can't do myofunctional therapy unless you can breathe well through your nose. So, and it's not actually a part of that. So nasal breathing comes first, but I will work with clients. I had a client with fibromyalgia, chronic pain. She was on a CPAP. She had 15 events every hour where she was struggling to breathe, and for years. And we were able to do some things. And the cool thing about having a CPAP is we knew her numbers went to zero. It was like, okay, this is your secret sauce to help you sleep. And it's a little bit different. For me, it was sleeping on my side. For some, it might be elevating the head of their bed. And again, it's not one thing, it's 5 or 10 things. So
Yeah, and it has to be individualized, like you said, because some people, yeah, they sleep on one side and they'll tell me that they feel like their airway's getting cut off or their neck will shift or things, and then it disrupts their sleep versus the other side is fine. And so, yeah, it's so individual.
absolutely. No, you're absolutely correct.
Well, Dr. Bateman, the clinical care guide emphasizes that sleep hygiene alone, often that's one of the first things that doctors recommend is sleep hygiene, meaning go to bed at the same time. These principles of preparing yourself to sleep and getting good sleep, often it's not enough in individuals with ME/CFS, long COVID. Why is that, and what might be going on that contributes to poor sleep?
That's a really important question and kind of a complicated one. I'm so glad Cynthia talked about those steps for sleep hygiene, because I want to emphasize, I'm going to say why it isn't enough, but you also have to do sleep hygiene. It's super important to engage in all of those behaviors. But remember, some people have a primary sleep disorder, as she talked about, and sleep hygiene alone won't be enough. If you have obstructions, I'm really excited to be reminded about what Cynthia does, because sometimes we think people avoid going for sleep studies because they don't want to wear CPAP. But and sometimes you need to, but what's really important is sometimes there are lots of other solutions once we really try to understand anatomy and what the options are. So some of the things that can make it so sleep hygiene alone isn't enough is a primary sleep disorder, for sure. Some of our patients have pain that wake them up from during the night, or they have urinary frequency, or they're really are in a noisy environment, or they have mental health conditions. But what's really important, and what we've learned about this illness complex, is that there are at least three major things that are disrupting sleep. One is an abnormal stress response of the HPA axis. That's the hypothalamic pituitary axis. And you don't need to know all about that, but probably one example, because there are lots of hormones in that area, but one example is people with ME/CFS, well, normal people, their cortisol goes up in the morning to help them wake up and be energetic, and then it goes down by the end of the day to help people relax and go to sleep. But in our population, it tends to flatten out. It doesn't go high enough in the morning and it doesn't go low enough at night. So they're not getting that trigger to energize and wake up in the morning. And sometimes it may make it more difficult to go to sleep at night. And that's just one of the hormones that might be dysregulated. The second thing that's really important in the background is autonomic nervous system dysfunction. And this is along the lines of what we discuss when we talk about orthostatic intolerance and POTS. But there's a shift away from the rest and digest toward the fight and flight sympathetic nervous system. And especially if you've been upright a long time before you go to bed, you've got these circulating neurotransmitters like adrenaline and norepinephrine that make it hard to go to sleep. The third is central sensitivity. And we know about this in fibromyalgia, for example, because people have amplified pain. But really, there's sensory amplification in many patients. That means any sense can be amplified. It's sort of like the princess and the pea. So too much light, too much sound, too much sensation. I have a patient whose husband built a soundproof room in their basement because she could not sleep if there was any noise, despite earbuds and all of those things. So those three really important processes that affect your whole body are probably at play in people with ME/CFS. So that's why sleep hygiene alone and also treating a primary sleep disorder sometimes isn't enough. They're all important. And we can talk more about that if we want. And also they put in the chat that a lecture I gave to physicians and medical providers about these nuances of sleep disruption in ME/CFS. So if you want to look at a more detailed view.
That's really interesting, those points. Do you feel like a lot of people have pre-existing sleep issues that then when they develop ME or long COVID, that those just get worsened, but they were already kind of there? Or
Yeah,
do you
sometimes.
see that?
Sometimes, I mean, we all bring our physiology with us, and some people are wound tight, but those are the people that respond to sleep hygiene, right? They learn how to, if they're type A or they're wound up or their thoughts are racing when they go to bed, practicing all those sleep hygiene and learning and developing skill at that can help a more normal, a person learn how to sleep without needing medications. But sometimes, and we talk about this more later, sometimes we have to complement our sleep hygiene with treatment of primary sleep disorders, but sometimes other kinds of disruptors.
Do you find, one more question, do you feel that getting a sleep study would be helpful for patients? And if so, what should they tell their doctor beforehand so that maybe captures more than I know it's individualized, so some people it may not be worth it to get a sleep study, but
Right. I mean, back in the old days, we couldn't order a sleep study unless someone was overweight and snoring. But I've learned that those are not necessarily predictors. I think eventually, you don't have to do it knee jerk in the beginning, but eventually, if sleep hygiene and other things don't straighten out your sleep, I think everybody needs a sleep study of some kind. Everybody who has this illness complex, ME/CFS, because you want to implement every modality to improve your sleep. It's not a quick fix, but it's important. That gives you a treatment avenue that can complement what you're doing. And I think the studies vary, but I've seen studies that say more than 50% of ME/CFS patients have a primary sleep disorder. And remember, this isn't just obstructive or even central. It's also restless legs and your legs jerking at night and narcolepsy and all of those kinds of disorders. So knowing about them is a really good idea. So, but you can just say things to your doctor like sleepy all day, snoring, right? And that about getting a sleep study. it's up to the doctor sometimes to give the right clues to get insurance to cover, but it can be done in almost everybody.
And do they have options for patients who can't go in, who maybe need to do it at home? Like if they have severe symptoms, are there
Yeah,
options to assess it from home?
there actually are, and sometimes they're a little limited by insurance, but of course there's a polysomnography, which is in the sleep lab, and people sleep overnight there, and that's kind of the gold standard because you can learn so many things and do brain waves and your heart and all of that. But more and more people are doing a home sleep study, which is very similar. They can bring the equipment to your house, hook you up. It can't do the brain waves, but it can do your breathing and your heart and your legs to see if they're restless. And home sleep studies have been a great, and sometimes they'll do more than one night because it's not as expensive, right? To have, have to go into the lab and have someone observe you. And at the very least, I have people do an overnight oximetry because the worst kind of sleep apnea is if your oxygen levels go down as well. But as Cynthia noted, that frequent awakenings are enough. You don't have to have your oxygen go down to have your sleep disorder negatively impact your energy the next day.
Yeah, that's so helpful. It's interesting. I had a patient one time who she had a Garmin watch that would track her stress and sleep and things. And what we found was that her highest level of stress was actually during when she should have been sleeping, when she was sleeping. And then in the morning, so her body battery score, which kind of is an indicator of her energy, would drain as she was sleeping. And then in the morning, she'd still feel really unrestorative, unrefreshed. And so then she would lay and just with her eyes closed, not sleeping, but just laying there calmly. And then her body battery would go up. And so I sent her for a sleep study, and they found that, yeah, her oxygen was dropping and other issues that then led her to getting treatment. And she started getting less migraines and better sleep. So that's so helpful. Since you mentioned studies and checking brainwaves and things, I want to hear from Dr. Mullington. You're involved in a lot of the Recover initiative, which are studies looking at how long COVID affects sleep and other aspects of the body and health. Can you tell us a little bit what researchers are learning about sleep disturbances and
Sure.
in individuals with ME/CFS?
Sure. Well, with Recover, it's a tremendous initiative that has different components. So there's a pathobiology component that is an observational study, and it has enrolled over 15,000 adults across the country. There's over 17, I think there are 17 hubs, many sites across the country who have enrolled participants, and they have monitored their symptoms across time. So many of these people have participated for 4 years and done surveys every 3 months to document their extensively document their symptoms. And in addition, they had other tests performed, like physiological tests. Blood was collected. And so there's a huge wealth of data that's now being worked up, and publications are coming up. Anybody can check out all of the studies, and there's the recovercovid.org site that is a rich resource. I've been involved in my particular area, of course, being sleep. I've been involved in working up some of those data. We have a paper now that's under review and hopefully will be published very soon, looking at over 4,000 participants' wearables. So there were wearables given to people who were willing to wear them. And that data is showing really quite striking sleep efficiency difficulties and sleep irregularity Of course, as Dr. Bateman was describing, the sleep irregularity may be because of underlying sleep disorders. And I agree that there's data is showing about 50% of the patients who develop long COVID have pre-existing sleep disorders. So it can worsen that sleep disturbance. And in addition, I've been involved in research where we're looking extensively at the EEG. And I should say that we're soon going to be able to analyze the EEG from the Recover COVID initiative, because many of the studies who participated in that observational study have also had facility sleep studies with EEG. And so we'll be able to analyze that. I don't know if you would like me to share some of the data that we've been looking at with regards to the EEG, but we are seeing a signature in the sleep EEG of people with ME/CFS and long COVID that shows an abnormality of the phase relationship between spindles, which are a feature of non-REM sleep, and slow oscillations, another feature of non-REM sleep. And there's a relationship between these slow oscillations and spindles that is different in people living with ME/CFS and long COVID. I can show that if you'd like.
Yeah, no, that gives me hope that, like you're saying, that they're finding things that can maybe be addressed and some abnormalities that
right. And there's new methods of non-invasive brain stimulation that are being developed, and these may actually be used to help restore the quality non-REM sleep, quality slow wave activity. So I'm very hopeful about future possibilities of interventional studies using those methods.
That's excellent. Yeah, that's so good to hear, because often we hear that there's research being done, but it doesn't seem like it's a slow process to see change. And so
it is. Of course, there has to be, we have to try and understand the mechanism, and then have to be very careful to replicate and validate what we find, and then develop the best treatment interventions and test those as well. So that all does take time. It has to be very carefully done.
Yeah, and you had mentioned, so we've known that with ME/CFS that people wake up feeling unrefreshed, and that it's unrestorative sleep. Regardless of how many hours someone sleeps, they can still feel very exhausted, and like the sleep wasn't that helpful. With these research studies about sleep, have you seen, how is it different? How is sleep with ME/CFS different from normal sleep?
So there's actually a study that was done some years ago, and Armitage is the first author, where they found that it was a twin study, and they found that the affected twin, so the twin who had the symptoms of chronic fatigue and unrefreshing sleep, had a lower, what we call a homeostatic drive, which essentially, I was talking about slow waves, and we've talked about the importance of the deep slow wave sleep. And this slow wave sleep dissipates across the night. So you start out, and in the first third of the night, you have more slow wave, and it drops across the night. And in healthy sleepers, it drops thoroughly, and you wake up feeling refreshed. But in the people who have the ME/CFS, they do not get rid of that homeostatic pressure as well as the healthy sleeper. And therefore, they wake up feeling like they didn't sleep as well because they didn't. Their sleep is also more inefficient. So there's more fragmentation, more waking up through the night, and often more of what we call alpha delta. So alpha is normally associated with wakefulness or quiet wakefulness. And in many people with ME/CFS, it is riding on top of those slow waves. So it deteriorates the function or the quality of those slow waves, which we
Yes,
think are restorative.
that's helpful. Yeah, sleep is so fascinating because it's something everybody does every day, but it's a whole process that the brain and body go through that we hopefully are getting a better understanding of with all of this research and how to help. Cynthia, we have some questions in the Q&A that I want to address to you on how to maybe manage some of the issues. Like, so someone asked, how do you balance taking in plenty of fluids for POTS and not having to get up to go to the bathroom multiple times in the night? That's a hard one, right?
That is a hard one, and it's so important. And I love Dr. Bateman has some tricks with this as well. But I have my patients hydrate, drink as much as they can during the day, but then stop at a certain time. And, they just truly limit them in the evening. But then listening to Dr. Bateman's talk, she talked about elevating. I elevate during the day, elevate your extremities to get those fluids back, especially if you're not. I wear compression socks. That helps. I love my compression socks, but that helps return the fluids during the day so you're not doing it all at night. So there's lots of little secret hacks from these amazing professionals. So
Yeah,
great
I'd
question.
agree with that. I've seen like if someone elevates their legs, that then soon after it's like I need to go to the bathroom. All that fluid then is able to be processed, and so elevating the legs before bed, not drinking as much before bed can be helpful. Drinking the little sips of fluids throughout the day versus like chugging big amounts at one time, you can absorb more. And then also, would eliminating caffeine help provide more restorative sleep? I know that's a probably individual for each person and may be different, but do you have any thoughts on that?
Some people do well with it and some do not. So it's just precision. We have to figure out for that person what makes difference. And limiting it, it's got a half-life, and you may know better, but
Yeah.
there is a half-life. You have to stop it at it's like 2 in the afternoon or something for for some. So
Okay. And the last one, some people asked about how to handle, and I hear this all the time, this feeling tired but wired before bed. And so the person wants to go to sleep, but it's just the nervous system is in a state of not allowing the body to get into that restful sleep. Do you have any suggestions for that?
So some of the things I recommend, some of the research shows, a warm shower. I recommend like an hour or so wind down where you're kind of get things out of your mind, rocking, humming. You need to de-stress, forget about your worries. I try to do my planning right after dinner so that I'm not doing it right before bed. And I keep sticky notes under my pillow. So if I wake up in the middle of the night with an idea, I write it down with my eyes closed and I throw it on the floor, but I don't have to open my eyes and I don't have to stay awake to remember it. So for me, those little hacks, you have to find the little hacks that work for you and kind of customize your own plan based on all of the experts that you have, your team.
That's excellent. Thank you. Dr. Bateman, do you have any interventions that you've seen helpful or that make a big difference for sleep with ME/CFS?
Um, I would say just in short, one is sleep hygiene, and that's a broad category. That's everything you need to do behaviorally to prepare your body for sleep, and we've been referring to some of that. The second is I work hard to identify what the sleep disruptor is, right? And don't just drug yourself to sleep, but is it restless legs? Is it pain? Is it going to the bathroom? Is it, your mind racing and you have to turn it back off? And or taking a medicine during the day that's lingering and keeping you awake. So I always start with trying to identify the most prominent sleep disruptors and then aim the treatment at them, at those things. And sometimes it's behavioral and sometimes it's medications. And there are strategic ways to use medications, and maybe we can talk a little bit more about that if we have time. But what I like to remind people is natural sleep is the best, right? Sleep without drugs is the best. But I think the biggest challenge I've had in my whole career, other than teaching people how to pace, is helping people establish the most restorative sleep possible with their disease. People just, it's hard to achieve restorative sleep with this disease. So I think that's a high bar. We want to improve it the best we can. It's rare for people to wake up perky with this disease. There's just too many things and impacting the fatigue. But you can work on establishing the most restorative sleep possible. And then the medications should be used carefully and in small amounts and move away from them when you don't need them. I have a much more detailed discussion of medications in the lecture that is posted if you want to look at it. And even the clinical care guide just made a few suggestions. But there are many, many things that are safe and have been utilized. You just want them not to interfere with your daytime awakeness, right? So when you take medicines at night, you don't want that spilling over into the day in a way that makes you sleepy or have more brain fog. And so it's working with carefully with the different factors that are upsetting the sleep.
Yeah, that makes sense. Have you noticed that? I know you mentioned this to me that we talk so much about pacing being so important with ME/CFS to pace activities and rest and things. And sleep is one of the main factors that there's this unrestorative nature of the sleep. You mentioned that managing sleep is next to pacing. Can you speak more about that?
Yeah, I mean, this really comes from the hundreds and hundreds of patients I've talked to about their sleep. And it's pretty impressive, actually, right? And people have told me many times that they feel much better in the day if they're able to get a decent amount of sleep, and they feel way worse during the day, the more disrupted their sleep is. Some other little things is people tell me that it's really hard for people to get to sleep sometimes, both at the beginning of the night and in the middle of the night. But the thing that's always stuck with me is if people aren't allowed to kind of wake up when they're done sleeping, they also feel horrible during the day. So, setting a jangling alarm or something like that to get up before you consolidated your sleep can be very difficult. So yeah, it's really very challenging. And I almost forgot the question. I was going off on so many
No,
tangents.
no, you're good. No, that's great. I think you've emphasized the importance of
Oh, yeah.
pacing and sleep,
Why
those
it's so
being
important.
two very helpful things. And so, no, you did great. And I feel like uh, the other question I have about that is naps. Should often people ask, well, should I try to cut back on the number of naps I take during the day? And I don't have as much experience with advising people on that. So if you feel like you need a nap, I kind of recommend that you take a nap then in the middle of the day. But what are
Um,
your thoughts on that, on
It is
napping?
complicated and needs to be individualized, right? But the important thing is if you take a big long nap and then you can't go to sleep at night, you're sabotaging your sleep, right? Your body needs a certain amount of sleep, and if you take that sleep earlier, then it's going to be hard to get to sleep at night. So you want to attempt to consolidate your sleep during the sleep time, but some people really need to take a nap, right, for their exhaustion. I try to get people to put their feet up and hydrate and relax. And then if you have to sleep, or if it's restorative to sleep and doesn't disrupt your sleep at night, I think you have to use your good judgment about that. The other thing I wanted to add on the other question was, one of the things that's made me also feel how important it is to work with sleep is I've had a lot of people gradually get a lot better, right, and return to many normal activities, but it's usually their sleep that's fragile still, even when they're better. And I have patients who need to stay on a little bit of something to have that, confidence that they can maintain their sleep. And a period of sleep dysregulation could crash people. I've had people who have, who really end up back in a bad situation. But that said, I want to also say you can't get obsessive and scared about sleep, right? If you get too observant and too worried about it, it kind of destroys your sleep too, right? So you want to just work with it and try things and monitor to a degree, but just kind of lean into it and work over time about getting your sleep into a better place.
Yeah, and I'm glad you mentioned that. If someone is doing activities, overexerting, and then it triggers post-exertional malaise, research shows that when you have post-exertional malaise, that also causes sleep disturbance. So they go
That's
hand in hand, where if somebody's overexerting, then that's going to mess up sleep, and then that then messes up. It's a cycle.
Yep.
So yeah, it's so important to make sure that pacing is emphasized, because otherwise sleep goes down the drain.
Right. Preventive pacing is by far the most important intervention in ME/CFS to avoid, you can't avoid all post-exertional malaise, right? But you want to avoid severe and prolonged post-exertional malaise. You want to allow your body to recover in time before going and doing too many things. Pacing can cause anxiety too, right? I mean, I talked to a patient yesterday who was afraid to do anything, right? Even though I was pretty sure he could do more than he was doing. So sorry, I can't help but talk about pacing, but it definitely, not pacing and getting in post-exertional malaise can certainly deteriorate your sleep, but don't panic, right? Because when you start to rest and recur and go back to your patterns that were helping, you'll gradually get back to a better sleep pattern.
Yeah, that's so true. Yeah. Cynthia, what questions do you usually ask your patients about sleep? Like, what things do you ask people to determine what might be going on?
Yeah, so some of the things I track are how many times they wake, their wakings, how many of those are bathroom breaks or just awake, like getting awake, how they feel when they get up. Do they feel good? Do they have a headache? Or is their jaw sore? Like what symptoms, what position they're in? Like I try to track like when you wake, are you in a certain position maybe? And just have them kind of describe an average night. I've had some people, I had one patient who was like listen to horror movies like would play during her sleep. And she's like, and she would get up and change the channels. And I was like, that's probably a problem. And, but I know some people who, listen to something. I've listened to a boring book that I don't care the outcome before just to help sometimes calm my mind. And that's been helpful. So people have to find what works for them, but, sometimes they're a little off.
Yeah, no, that makes sense. If you're listening to something like a horror movie in the background, that's going to have spikes and things in
Especially
volume. And
if you're changing the channel. If
yeah,
you're changing the channel, you're definitely waking up. That's a problem.
that makes sense. We use sound makers and things, and I've noticed if we don't have sound makers, it's a lot different. We were actually recently camping, and we were getting woken up by cows and coyotes and ravens, and it was just like, wow, I don't know how people slept before they had rooms and sound makers. Um, so some of the comorbid conditions, someone asked in a Q&A about Ehlers-Danlos. and how that can affect sleep. And so this is for anyone to answer, but just in working with individuals who may have instability or a lot of loose joints in the neck or shoulder or other things, that can also affect sleep with subluxations or pain. And so we do a lot as physical therapists and then occupational therapists to try to set up an environment in the bed that there's cushioning, there's protection. Some patients will even use a cervical collar so that as they're sleeping, their neck stays in the same position. They don't wake up with it in a different position that's cutting off the airway. So I don't know. Do you also look into those things, Cynthia?
I did want to mention something that's not always discussed, and that's trauma. So I have some people who've been abused in a bed. They have, or there've been traumas in their life. Certain positions or sounds or smells create trigger trauma, and they don't feel safe, and then they struggle to sleep. So that's something and that's going to fire your nervous system. You're in fight flight. So that is such an important piece that again, I didn't mention that, but I wanted to just quick share.
That's excellent. Yeah, I think that's such an important piece as well to address some of those things, whether that's with a behavioral health provider or yeah, that needs to be addressed because those spikes can definitely cause disruptions in sleep. And even when we first started having kids, what I noticed was we became more sensitized because we were listening for crying. Our nervous system was more on alert that any noise, then the brain was monitoring because it could be crying. And so we needed to wake up, and we became more sensitized and had more fragmented sleep because of that. Dr. Mullington, if you could give patients one message of hope from what you've learned in the research and kind of what you're seeing develop, what would you say?
Well, I would say a few things. I just wanted to, for a moment, go back to what Dr. Bateman said about napping. I think one thing we know is that there's a phenomena called sleep inertia. So when you wake up from a nap, or if you wake up from deep sleep, you will be more groggy. And having a short nap might actually help with regards to the nocturnal sleep, improving the quality by not sleeping too much during the day. I think that's a really important point. But there is evidence that a short nap can be restorative. So maybe trying to curtail, I would say that the evidence suggests that in general, having a short nap can take some of the sleepiness pressure away without, building up too much sleep so that you can't sleep at night.
Is there a way to determine how short, like 10 minutes, 20 minutes?
Yeah, I mean, at least we've done research in narcolepsy and in healthy sleepers. And even a 15, 20-minute nap can really help, discharge some of that sleep pressure and not be so much sleep that it impedes your ability to sleep at night. But with regards to optimism about, what do I feel hopeful about? I really think that these, as I said earlier, these non-invasive techniques they are really technologically developing very quickly right now, and it might be possible that the deep sleep quality can be enhanced. Certainly, it's being demonstrated and tested now in healthy sleepers who maybe may have curtailed sleep, shortened sleep under experimental controlled conditions. But I think that these systems are rapidly being developed, and there's a call out now for proposals from the government, federal funding, to see if these systems, to test these systems, and not in clinical settings, but in research settings right now to see if which ones are most effective and what's the best way. The idea is that wearing a stimulation cap or headband of some kind may be able to, in a closed-looped way, so meaning that the system may be able to monitor the brainwave and produce a stimulus to help enhance the slow waves. So that technology is coming, and I think it would be extremely helpful if it can be tested and get to the point where it might be an intervention.
Oh, that's really fascinating to be able to monitor it in real time and then correct those sleep abnormalities when they're
Exactly.
occurring.
Yeah. So some teams are now looking at, what point on, I mentioned these slow waves, and you can, through some of these closed loop systems, you can actually apply a stimulus at a point in the slow wave to help augment the slow wave. So it's a real precision feedback system that may actually help to improve the slow wave. And I hope that comes within the coming years. As I said, they're putting out calls for proposals now, so hopefully this will be something in the future.
That's really fascinating. We have time for maybe two more questions. So one I want to ask is, with studying sleep, how do you not disrupt it when you're studying? Often they have people come in for a sleep study into a lab and sleep, and that's going to change how they normally sleep. How do they study sleep without also disrupting it or making it different because it's a different environment? Or
Sure. Yeah, well, I mean, in the facility, so if you go to a clinic for a sleep test, there's definitely what we call a first night effect. That, the environment in itself, it's all strange, it's new. And probably even when you go to a hotel and sleep for the first night, it might be that you don't sleep as well as you do in your own bed. So yes, there is that disruptive quality, but what we find is that you get enough sleep to see if there's something like sleep disordered breathing occurring, which even if you don't have the sleep you normally have at home, you'll be able to see. And in addition, we have methodologies, as Dr. Bateman was describing, where you can send a home sleep study. And even though the home sleep study doesn't have the brainwave monitoring, the EEG typically, it can tell you if you need to bring somebody in and have a facility study. There are some EEG systems that can go into the home, but they're not as readily available. There's also now, I think, the wearables are improving, and I really do agree with the comment about doing a home oximetry, which is very easy to see if there's desaturations across the night. So those are technologies that are used clinically. They're also have been used in research. And I think the wearables, we have an opportunity to really study large populations. And, you mentioned the garment. All of these different wearables have tremendous opportunities to let us look long term, because in ME/CFS and in long COVID, we often hear that symptoms may not be consistent every day. So there's and with PEMs. So I think that the wearable technology and momentary assessments that we can have through apps can really help facilitate the home monitoring and the pacing approaches as well.
Thank you. That's so helpful. Dr. Bateman, one last question. This one comes up all the time with patients that I see is CPAPs are annoying. And how do you tolerate a CPAP when you're trying to sleep and it's obstructive, or it's supposed to address obstructive sleep apnea, but it's also obstructive and annoying.
Yeah, that's really true. My suggestion to people is to do the best you can. You've got to give it a really good trial. You can't just, try it for 2 nights and say, I can't do this. Explore different masks so that you understand the different fit and the different masks. If you absolutely can't wear CPAP, there are other alternatives. I mean, I'm not a sleep specialist, right? But you can have surgery on your tonsils. You can go see Cynthia and, improve your the anatomy there. You can go to the ENT and make your nose better, right? So that you can breathe through your nose. You can learn more about body position. And there is an implantable device now, and there's lots more in the future. And I'll confess that I was pretty sure I had sleep apnea and didn't want to go to the doctor and didn't want to wear CPAP. So I lost weight and learned how to sleep, in the right position and always sleep with the head of my bed up. And I'm pretty sure it's gone away. Right. So, and the last thing I wanted to say, I know it's time to end, but I love wearables, and they've gotten really good. And when the Oura Ring first came out, it was stunning to me that you could buy the Oura Ring for the cost of one polysomnography, right? And you could monitor your sleep every night. Just remember, with wearables, don't take them literally, right? They give you ideas, but they're designed for people who are healthy, and it may give you a little bit of strange information, but as you learn about it, you can assess your meds, you can assess, when you're in PAM, you can really learn about your sleep. And kind of the last thing I want to say is it's really your job to understand your sleep and what you can get some help, but it's really up to you to understand what the disruptors of sleep are and work on them.
Thank you. That's super helpful because that covered a lot of different things that people bring up, wearables and CPAPs. And well, thank you everyone for joining us. We hope to see you again for our next session on Wednesday, August 12th at 10 a.m. Mountain Time, where our next session will actually be different. We're going to have a special event for Severe ME Awareness Day in collaboration with Open Medicine Foundation, ME Action, Solve ME CFS, and the writers of the What is Myalgic Encephalomyelitis Like book. So it'll be a special event, and we look forward to seeing you there. We'll send an email with the recording and other resources at the end of the month to those who have subscribed to the Bateman Horn Center emails. And please complete the brief survey if you feel up to it that will pop up on your screen at the end. That helps us to know how to tailor these sessions to meet your needs and answer your questions. And so we look forward to seeing you next month. Have a great rest of your day.